Hello, my name is Michael Ivan. I'm one of the brain tumor and skull-based surgeons here at the University of Miami. I'm also the director of our brain tumor program for research. It's an honor for me to be joining you today and to be invited as a guest speaker at the Computational Neuroscience Outcomes Center. Really a privilege to be speaking at the symposium with some really great speakers and for me to be talking about our own work here at the University of Miami on the use of artificial intelligence in brain tumor surgery. I am a consultant for Medtronic, and that's my disclosure. So before I talk about AI and brain tumor surgery specifically, I have to introduce the technology that we're applying it to, and that is Raman Spectroscopy, used for rapid frozen sampling of brain tumors. Now, currently, we all know we use frozen pathology to make diagnosis intraoperatively, and this technology has really remained unchanged since it was developed in 1905. Raman spectroscopy uses the intrinsic vibrational spectroscopy properties of biological molecules within the tissue. It's the ability to look at these differences between lipids, proteins, DNA, etc., which is different in all different kinds of tumors and neurological tissue. And when you look at that, you could apply different colors and shapes and basically then develop a picture. And this work has been greatly developed by Dr. Oranger and others at University of Michigan and has been published widely. And at the end of their research, they developed this system, which is seen here on the right, which is now produced by Invenio, and it's called the NEO imaging system. And what this does is uses stimulated Raman histology to provide instantaneously tissue visualization like a frozen. As we all know, a frozen sample consists of collecting the tissue in the OR, freezing it, cryostat, cutting it, and then staining it in multiple steps to then get your frozen sample. In this workflow, the patient's tissue is placed directly on a slide in a squish prep, and then that slide is placed directly into the machine, and within 30 seconds, you have an image that can then be shared digitally into the operating room as such or over to the pathologist. So the question is how good is this technology? Well, if I just show you a couple pictures just for representation, here's a meningioma and Raman on the right and frozen on the left. You can easily see the pneumoma bodies. Pituitary adenoma, you can easily see the cytoarchitecture of the adenoma. For more rare tumors like central neurocytoma, craniopharyngiomas, and chordomas, again, there is resemblance of the key structures needed to make the diagnosis. In addition, cholesterol crystals here in craniopharyngioma, you can't even really visualize well in a frozen because the artifact from a crystal is not picked up well in a frozen sample at all. Glioblastoma, also very, very easy to make the diagnosis. And the progression from normal brain to low-grade glioma to high-grade glioma is easily seen not only with the increasing cellular proliferation, but also with the kind of pseudopalisading and necrosis seen here in the glioma. And so here's one of our patients where we took the directed guided biopsy samples and then looked at the Raman spectroscopy. You could see the different areas of the tumor very clearly. Here's the necrotic center, here's the ring enhancement at the outer edge, and here is with the outer flare seeing kind of this disbursement of the tumor cells. Here's another example of how it would be useful in a tumor case. This is one of my grade 2 meningioma cases that I did last year. With very infiltrative tumor involving the sphenoorbital area. We performed a skull-based surgery extending into the right middle fossa. And as we went through the tumor, we were able to take different biopsies. And so here we can see the meningioma itself. As we go more anteriorly, we were able to get to the border of the lacrimal gland and sample that. As we went down to the middle of the tumor, there was a necrotic center, which actually was able to be seen on the histology. And we could immediately make the diagnosis. This is an atypical meningioma. Here we could see the infiltration of the meningioma within the bone. Again, bone artifact, very difficult to see in a frozen because it's difficult to sample. And then finally, how the tumor invades into the temporalis muscle here on the lateral aspect of the tumor. So we weren't using this for margins per se in this case, but more to just understand how easy is it to see the differential areas of the tumor and how it invades. Here's the post-op scan here on the right. So in order to understand how accurate this is, we developed our own validation trial here at the University of Miami where we looked and compared SRH versus the frozen. both to look at accuracy and timing. We looked at 82 patients, and if you just compare specifically lesional versus non-lesional tissue, you could see here the pathologist was able to confirm that to 95 and 93% of the cases, whereas SRH was actually 95% accurate, with the specificity and sensitivity very, very high. And on the right here, if you look at the correct kind of diagnosis being made by the pathologist or by using either SRH or the frozen, you could see that in each case, there was actually errors made in different areas, indicating that if you use these two technologies together, both frozen and SRH, there could be synergy, and you could actually provide a more accurate frozen diagnosis by using them together. There was no surprise that the Raman spectroscopy performed much, much faster in here. And if you look at the distribution, the mean time was about 8 minutes. And I could argue that that would actually be much lower, down to 3 minutes, if we were able to optimize the IT and the Wi-Fi and the technology in our hospital better. And here's the frozen time where we were at 39.5 minutes. If you compare the accuracy between the Raman histology, the frozen, and the permanent, there was actually no significant difference with how each one of those compare in and of themselves. Obviously, there's limitations to the technology or any new technology. There's a learning curve with pathologists. There's obviously always going to be sampling error in biopsies. There's always difficulty with understanding necrosis and hemorrhagic lesions. And so further studies may be needed, especially with understanding how to use this technology to look at margins and extent of resection. But in our conclusions for this study, we were able to identify that it is a huge savings for time if you're waiting for the diagnosis, or if you were waiting to understand margins. It remains very accurate for identifying lesional tissue, or even actually the type of tissue. And there is potential here to use it for surgical margins and visualization. Also, it's very easy to then use it with remote pathologists and other areas. And our microscope is very portable and can be used in multiple OR settings at a time. So then taking this technology and then applying artificial intelligence was really the next key step. And I can't take that was really Todd Holland and Dan Oringer in Michigan who decided to look at this. And what they wanted to do was use deep neural network learning or machine learning by training AI on 2.5 million Raman histology images with the 10 most common brain tumors, and then with non-lesional tissue, to see if using this, can we develop a network that could then read future images. And so after this was developed, we then used 278 samples from the University of Michigan, University of Miami, and Columbia with these 10 samples to see how well the AR could then predict the tumor itself without any intervention from the pathologist or with any clinical data whatsoever. So how does it do that? Well, it looks at basically the patterns, and it looks at the hierarchy of the patterns within each slide, identifying the colors, the contrast, and overall shape of the patterns within it, and then labels them with each tumor type. And then as you look and learn more and more, it could actually help make the diagnosis. The outcome, well, the pathologist accuracy on frozen in this study was 94%. And with the deep neural network, it was 95%. And I would argue that the neural network was actually handcuffed because we did not provide any information to this, like the age of the patient, the location of the tumor, intrinsic, extrinsic, intraaxial, extraaxial. And if you could subsegment those samples very easily with that information, this accuracy would probably be even higher. The other thing that was interesting is that we were able to start to understand the margins of tumors and how it infiltrates into gliomas, indicating this could be a tool where you could actually even use AI to understand margin analysis instantaneously. So where do we go from here? Can we extract more information from the tissue than just the diagnosis, such as mutational status or RNA ability? And we are starting to see that initially. Very early data is coming out now that we could look at that. Are there going to be other details from these digital images that will end up being more important or for prognosis and prediction of tumor, such as the cellularity or the cytoplasmic nuclei ratio? uh, things that you couldn't calculate before that now very easily with digital technology you can, and that very well may come out of this. And how we link this to molecular analysis is obviously key. So where do I see the future of artificial intelligence in neurosurgery? Well, we can apply these deep neural networks already to radiology. This has already been shown in breast cancer and head and neck cancer to identify areas of hotspots within the tumor. Imagine the patient goes intraoperatively to an intraoperative MRI, and AI identifies exactly the most likely place to find the tumor. The patient then gets robotic sampling, which we already know how to do, to that location itself. And then immediately after biopsy or within the biopsy itself, can you automatically tell and make the diagnosis, again using AI, what the tumor tissue is. So within that period of the 3 or 4 hour operative experience, the patient would be imaged, it would be characterized, it would be biopsied and diagnosed, and the patient would leave with a diagnosis after that similar procedure. Is this possible? Yes. I mean, can we do this right now? We're close, and we're all working together as a team, especially here at the University of Miami, to accomplish something like this. I have to acknowledge the great team, especially at the University of Miami, uh, um, who led the validation study. Of course, I can't thank enough Dan Oranger and Todd Holland for helping develop this equipment. Also with Invenio for their support, Christian, Zia, Corey, and Jay, and our pathologist, Dr. Butikin. If anybody has any questions, please feel free to reach out to me. Here's my email, and I'd be happy to interact with anybody. Thanks so much.